You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
Okay, so our case 2 is a 48-year-old female. She has a past medical history of preeclampsia with both of her pregnancies and a family history of early heart disease. Her blood pressure is 159/96. You've already taught her how to properly check her blood pressures at home. She comes in with her average. It's 151/93. Her hemoglobin A1C is 6%. She has no other evidence of end organ damage, but she says, I just hate taking pills. So which of the following might lower her blood pressure the most? Fascinating. Losing 5 to 10 pounds of weight, 46%. 15% selected exercising at a moderate intensity. Alcohol reduction, 9%. And 31% chose following a DASH-style diet. Now, we talked about a lot of these earlier today. Dr. Jones covered some of these in his earlier talk this morning. Following a DASH-style diet is probably the highest single thing that one could do, although... well, at least on this list, for certain, the highest single thing. So let's talk a little bit about weight loss. This is a table that I've modified to include what I would call the dose of the intervention that you're advising. So a patient might expect to achieve a millimeter of mercury reduction in systolic blood pressure for every kilogram in weight loss, up to about 5 millimeters of mercury. And I think it's really important to spend a little bit of time talking to patients about this, because if people feel like they need to get to some mythical weight, you know, the last time I fit in my skinny jeans, or wedding weight, or high school graduation weight, and it's just too overwhelming, it's hard for them to even get started. And so I think making the point that those first 5 to 10 pounds has the biggest bang for your buck in terms of blood pressure lowering goes a long way. So I think it's really important to get very granular with patients and say, you don't need to achieve some mythical goal weight. Let's just get started. Let's start with 1 to 2 pounds, and we can add from there. Exercise and alcohol moderation. Dr. Jones covered the alcohol moderation beautifully, so I'm not going to talk about that anymore. Exercise. On here, I use 150 minutes a week of moderate intensity exercise. There's actually also really interesting data that resistance training twice a week, or even isometric exercises in patients who can't do more conventional exercise, can help lower blood pressure. And so even for our most sedentary patients, there is something we can advise that they can do in terms of lifestyle modification in order to get their blood pressure down.
And that's kind of new. That form of exercise is kind of new.
Mm-hmm. And then these are dietary recommendations. The DASH-style diet is a pattern. DASH stands for Dietary Approaches to Stopping Hypertension. And it's a pattern of eating that can be applied to any cultural diet, any type of... So if patients want to do keto or high protein, low carb, intermittent fasting, you can do all of those within a DASH diet. You can also apply it to different culture. I had fried green tomatoes last night. They were delicious. Fried green tomatoes may or may not fit entirely into the DASH diet, but they are a vegetable. But you can use components into any type of cultural diet. So if your patient prefers a specific dietary, cultural diet, you can apply features of the DASH diet to anything. There's wonderful resources online for applying DASH diet to different clinical circumstances. I'm not going to talk a little bit and much more about sodium reduction because that was also covered. Do you want to speak, does our panel want to talk a little bit about potassium increase? And I'm looking at Dr. Tuttle in particular because there's a risk with chronic kidney disease, but I'm sure Dr. Jones and Dr. Basile also have a lot to say about potassium increase in the diet.
I think it's very effective for blood pressure lowering, which is good primary prevention. And, really, potassium becomes a problem in people with substantially reduced GFR in most cases. Now, people with diabetes, I mean, usually it's, again, these are not cut and dried points, but in general, once it's more prevalent in people who have GFRs below 30, and people with diabetes who tend to have hyporeninemic hypoaldosteronism because of resistance to aldosterone at the level of the cortical collecting duct. Then we see more commonly hyperkalemia, probably around a GFR of 45. Now, these are not cut and dry, just to give you a ballpark. So people with diabetes are more susceptible. But that said, what we're talking about now is primary care and blood pressure management, and I hope more on the primary prevention side where it's very effective. The and both is, people who do have lower GFR, especially if they have diabetes, just check the potassium for heaven's sakes.
Right.
And then, I know we're talking about lifestyle changes now, but then there's sort of a balancing act between the drugs we give and potassium intake,
Correct.
right? Because a lot of the drugs that we want to give for organ protection raise potassium.
Correct.
So back to individualized decision-making. So I think for the general population that you're talking about, this is good advice. In advanced CKD, it may have to be modified to mitigate risk of hyperkalemia.
It says that in the guideline.
Yeah.
Yeah.
Other quick comments?
Yeah. Go ahead, Dan. You go first.
So my bias, I'm a believe in low sodium guy. So there's my bias. The reason there's so much weight improvement in blood pressure in the first 5 to 10 pounds of weight loss, a lot of it has to do if you cut your caloric intake by half, you cut your sodium intake by half. Yeah. And so there's a good bit of benefit, and you lose that sodium benefit when you go further into losing weight. And that, this, but I'm going to say it out loud. Most of the DASH diet studies were done under very controlled conditions. Either the food was prepared for the patient, or there were dietitians counseling the patients. For most of my career, I've not had the luxury of having easy access to referring to a dietitian, and it's pretty hard for me to advise somebody about the DASH diet. The other, and again, here's my sodium bias. If you look at the studies that do the DASH diet and sodium restriction, there's a good bit more benefit to blood pressure. One that was recently published basically did the DASH diet without sodium reduction versus the DASH diet with sodium reduction, and almost all the benefit was from sodium reduction. This was a prepare food at home study, and so. And
the picture of the patient looks like she's a self-identified black, and in the black, that was the strongest group that really had a nice reduction from that. In term from the DASH sodium part of the trial, in the potassium increase, it's not KCl tablets. It's fruit and vegetables. It's no trans fats. It's legumes and plants. And once again, social determinants of health. I mean, it's not an inexpensive diet. But Walter is not here tomorrow morning if there's fruits on the early morning breakfast. I mean, we have choices, but as you know, go into the supermarket, they're expensive.
It's hard. Well, to move us forward, I think back to our case, these benefits aren't additive, right? You can't take a little bit of A and column B. Not everybody is going to benefit the same, but none of this is going to get that woman's blood pressure to where it needs to go, okay? So none of this is really it's going to help, and we absolutely should spend the time counseling and working with her on this, but we're still going to move beyond that for our case. And so then our next thing to consider before we're starting to prescribe an antihypertensive is to remember that 18% of adults with hypertension are taking other medications that raise their blood pressure. And these are prescribed medications, but we can also think about over-the-counter medications. And I have, again, I adapted this from the guidelines, but these are medications that can interfere with blood pressure control. NSAIDs are one of the biggest offenders. They operate. Maybe you could teach us how they work to raise blood pressure.
Well, they inhibit production of prostaglandins, and that causes sodium retention. Prostaglandins are very important for tubular kidney function. And the other thing, too, besides blood pressure, they cause a decline in GFR. They also have GI side effects. So thinking more broadly again, But I think it gets back to the thing we talked about in another context earlier, is get rid of the junk drugs. Get rid of things they don't need and might be causing problems so that you can get them on the good stuff.
Right. And again, as somebody who's a primary caretaker of patients, this again is this communication with other specialists who may be prescribing these medications for our patients, not taking into consideration their blood pressure as they're thinking about their overall approach. So the other one I'll highlight here is oral contraceptives. Estrogen raises blood pressure in women, full stop, and figuring out how to safely get patients onto other pregnancy prevention medications or insertable IUDs or things like that is really, again, a multidisciplinary effort and communication. So important to think about all of these and peel any of these off that you can logistically before we're starting to prescribe medications or as we're prescribing medications to get patients' blood pressure to goal.
I think you need to have patients bring everything prescription in a bag, everything over the counter, everything alternative, anything they take in the day. They need to bring it to the office, and we need to look at the bottles. Otherwise, we're in the dark.
Good advice. So back to our case, her blood pressure is 151/93. Based on the old guidelines, she's squarely here in this stage 2 hypertension. She needs the non-pharmacologic approaches that we discussed, but she also needs to be started on medication without delay to get her blood pressure down to a safer level. So what are we going to start for her blood pressure?
Is she pregnant?
She's not pregnant.
She's not pregnant.
She's 48.
40?
48, right?
She's 48?
What was her BMI? Was she
Elevated. Yeah, she was over 30.
Okay.
All right. Ooh, again, you guys are in thirds, I feel like. About a third for lisinopril, 20% for hydrochlorothiazide, and 48% for amlodipine valsartan. So again, for me, the correct answer to this question is the combination tablet of amlodipine and valsartan. I'm going to tell you a funny quote from Keith Ferdinand. Keith Ferdinand is an amazing mentor and giant in the hypertension field. He said, if you want to look like a magician, change hydrochlorothiazide to chlorthalidone. This is one of my favorite hypertension quotes ever. Get into that later. So let's talk about guidelines recommending combination therapy. So this is the 2017 guidelines. Again, you've heard today, new guidelines coming soon. But initiation of antihypertensive drug therapy with 2 first-line agents of different classes, either as separate agents or in a fixed-dose combination for stage 2 hypertension in patients who are 20/10 above their BP target, which is this woman. So for a target of 130 or 80, which as we've covered today should be everyone, consider combination treatment for initial therapy if their blood pressure is over 150 and over 90. So let's talk a little bit about single pill combinations for hypertension. They're vastly underutilized in the United States, despite widespread use for other conditions. And here are just a few examples. So for heart failure, we're all accustomed to using combination for infectious disease, HIV, COVID, Paxlovid is a combination therapy, hepatitis C, tuberculosis, obesity, and dyslipidemia. We use combination therapies all the time for these different conditions. For some reason, it really hasn't caught on in the hypertension field, which I think is a shame. And there are multiple dual and even now triple pill combinations that are available that are generic and low cost. So I'm just going to, this is maybe Dr. Jones would call this the realistic or the true confessions. I just want to go through some of the pros and cons for combination therapy because I know these are things that are going through your brains. Like, why should I do this? Why shouldn't I do this? So on the pro side, you can achieve blood pressure control faster. There's synergistic lowering effects of 2 or more medications. And so a little bit of amlodipine and a little bit of valsartan are better than what you're going to get from either of those alone. Side effects for these medications are often dose-related. So lower dosages mean fewer side effects for our patients. There's a lower cost if they're covered by insurance. You reduce pill burden, which we're going to talk a little bit more about. That leads to increased adherence. Now let's talk about the con side, because these are the reasons that you're thinking of why you're not doing this. Dr. Jones spoke about this a little bit earlier. These may not be appropriate for frail elders to start. So I will say that as a caveat to start. That doesn't mean that if you have somebody who's tolerating 2 different antihypertensive agents, that you cannot then combine them into a single pill to reduce pill burden and increase adherence. But you may not want to start using combination therapy in our frail elders. There's clearly some classes of antihypertensives that should not be combined. So we don't combine those in single individual pills or in multiple pills. Copay and coverage may be an issue, but I'm telling you, this is not as big now as it was 5-10 years ago, even 2 years ago. And so again, we're all creatures of habit. Check your local formulary, find something that works that you know is covered, and use it with wild abandon. My personal favorite is amlodipine valsartan, but you do you, boo. Choose your local covered option that you're familiar with, that you know the dosing ranges for each of those medicines, and use it. On the con side, it's hard to titrate individual components. And so if you wanted to go a little bit up on the valsartan, but not on the amlodipine, you may not have that option, though many of them do contain multiple different options. And then if atypical side effects occur, it can be difficult to determine which medication it is. Now, I mean atypical side effects. If you start a patient on amlodipine valsartan and they get lower extremity edema, it's not a mystery to you which one of those medicines caused that side effect. If you start them on losartan hydrochlorothiazide and they get hypokalemia, you know which medicine caused that side effect. And so rely on that. Don't let that be a barrier to using these medicines. Sometimes if a patient gets nausea or a rash, you may be stuck having to go back to the individual components to tease it out. But in my experience, at least, that's been less. I loved this study. This shows that patients who are prescribed single pill combinations have improved persistence. And persistence is defined as continuing to take the medication as prescribed. This isn't even initiation.
Damn.
25% of the prescriptions that you write for blood pressure medications, patients are not going to fill.
Can I ask you a question,
Yeah,
Jennifer?
sure.
So we've talked about this in other contexts, too, like ACEs and ARBs get stopped too, right? So persistence or maintenance of therapy is important. Now, this is just thinking about a future state, so it's a hypothetical. But assuming zilebesiran goes forward, is this the kind of patient you might consider she doesn't like to take pills? She has she has stage 2 hypertension. In that study of zilebesiran, it was mild to moderate hypertension. She's 48, so probably beyond childbearing, or you have to discuss that.
Let's presume. Presume.
Is this somebody like that might benefit from a drug like zilebesiran, where it's a shot once every 3 months?
So I'm here for things that reduce pill burden because I firmly believe that there is a barrier to taking more pills. So I'm very excited to see what happens with that medication comes out and how that might work.
But at least that's the way so far it's been. I mean, it's aspirational, but imagining success. I mean, that's one of the targets, I think, is people like this individual who don't want to take pills, who need antihypertensive medication, and where a sustained effect that doesn't require pill taking might be beneficial.
I think when it's all said and done, I'm on the steering committee for the zilebesiran, full disclosure, outcome trial. And I think it's going to be Q6 months, not Q3. And for non-adherent patients, I think absolutely. And maybe for all patients. I don't know.
Well, maybe someone like this who just doesn't want to take pills.
Right.
Yes. But I don't know if you're going to show the next slide. This is what's really, do you have the arrows on there? Did you?
I didn't include arrows,
You didn't
Jan.
put the arrows
No,
on
I
there.
need to.
So this is a retrospective observational German study in which they looked at patients that were on single pills versus the same medicines on a fixed dose combination or a triple and the 3 individual drugs. And I mean, you should see the single pill. I mean, this is death. This is death. And then hospitalization and death is also reduced.
All-cause mortality.
Yeah, so, I mean, it's a strong, but it's retrospective and observational, but still, it's really strong. Can you go back to...
Just to walk them through this. The dark bar are the people who are taking the single pill with all the components, and the pale gray bar are the patients who are prescribed these same medications in these same doses, but as 3 different pills. And this is the difference. You didn't change anything other than how you're delivering the medication to that patient.
Yeah.
I don't know.
I want just to keep going back. I just want to make a couple of quick points on the pro side. Okay, so achieve control faster. So we used to say, and I remember saying it to so many people over so many years, start slow and go slow. Start slow and go slow. I think what we're saying now is get blood pressure controlled sooner than later. Because in the value trial, which I was part of, in retrospect and observation, patients that had their blood pressure controlled sooner than later, over 6 months, sooner than 6 months, had better outcomes. So I don't want to hit them over the head and get their blood pressure too low, but this is why the last guideline said there has to be communication at 1 month and follow-up. Telephone's great. Find out what the blood pressures are, make a determination. Doesn't have to necessarily be face-to-face, but control faster, that's better. Synergistic effects. So you started lisinopril at 20, and you're now faced with a little more blood pressure that you need. If you go up to 40, the doubling of the dose will give you incrementally a lot less blood pressure reduction than that first dose, with more maybe side effects than adding either amlodipine or HCTZ. It's a win-win, and most of the time they throw in the second drug for nothing. So I get pushback from folks about single pill combinations. I won't know what the side effect is and this and that. I mean, it's the next best thing. Now, if you want to then go to lisinopril 40-25 or something, I'm fine with that. But the up titration should be like, in a sense, with a statin. Pick a good dose of the statin, add ezetimibe. If you need more, go higher. Dan?
Yes, so all good. All good. Clinical judgment on who to hit hard early, who to see more frequently, and just pace it. Doesn't mean you can't lower the blood pressure fast. They just need some attention during that period of time. And again, it doesn't have to be face to face, as Jan says, but there needs to be contact with those people. Right. They need to be measuring blood pressures at home, and as you make the decisions. So the guidelines coming out, a new guideline will be out in August. I'm not supposed to say that out loud, and I'm not supposed to tell you anything that's in it, but I'm going to tell you one thing.
Don't tell anybody.
Yeah, don't tell anybody, yeah. So there was so this guideline writing committee has more primary care clinicians on it than any we've had in the past, as you can see. Anyway,
it's because hypertension is a primary care problem.
Yes, it's a primary care problem. So there's one of the rules in guideline writing is you can only use generic names. You can't use any brand names, and there's a good reason for that. But our committee fought for and got permission for the combinations, because it's so hard for you to remember what doses of which drug and to write the prescription with the right doses for those two drugs. We sought permission to use brand names so that it would be easier for you as a prescriber to
get the
pick a few of the combinations that you like and trust, and to write those easily in a prescription. So the guideline's going to have for the first time, some trade names in it. We didn't take any money to do that, and every combination that's available in the United States for treating high blood pressure is in that chart. So I don't expect you to.
There's one that was just approved last week, Dan.
Oh, yeah.
That one might not be in there.
That's yesterday, 2 days ago.
Amlodipine, telmisartan, and indapamide was just approved.
Yeah, I mean,
what's the name of it?
Oh, it's so hard to pronounce.
It used to be GMRX.
Oh, that helped.
It's George's company.
George Medicine is the name of the manufacturer. The trial name was GMRX2.
So telmisartan and amlodipine might be easier.
And indapamide, right? Yeah.
Thanks for watching. If you found this discussion valuable, be sure to subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.